Good afternoon, and welcome to the Methodist DeBakey Cardiovascular Journal webcast. Today, the topic is cardiac critical care. And those of you, as myself, have been around for a while, we remember the old days when we took care of critically sick patients in either a coronary care unit, a medical ICU, or a surgical ICU. And if we were lucky and we were in an academic center, we had some residents looking after the patients, and either ourselves or the attendings in the unit would maybe see the patient once or twice a day. And that model remained for many, many years. And if you were in a private hospital without residents, basically the attending physician, the admitting physician that took care of the patient, and if the patient was lucky, he was seen maybe twice by that physician. So that was a model that persisted for many, many years. And until sometime in the 80s, where gradually the specialty of critical care medicine started to develop, either from the respiratory pulmonologists, anesthesiologists were the two that most got involved the most with it. Now there's some cardiologists also doing it. And over time, that penetrated to the current era where we have a lot of ICUs managed by physicians who are experts, who take care of these patients, and it has totally changed the face of ICUs and the outcomes that we're seeing. Here at Methodist, we started that sometime in the early 2000s. We were extremely lucky to recruit Dr. Masud, who's still with us, hopefully will continue to be with us, who's done a fabulous job in establishing this whole field of critical care at Methodist, not only in our main hospital, but all through our hospital system. So when we met about a year ago, the editorial board of the journal, we felt that a lot has happened in this field of critical care that require for us as a journal to have an issue dedicated to it. And this is the issue. And we encourage all of you to go to our website, journal.houstonmethodist.org, or just Google Methodist DeBakey Cardiovascular Journal. And it's a wonderful issue written by outstanding experts in the field. And what I like about this issue is not only is an update on what's going on today in the management of critical care patients, but also even a look into the future of some of the new things that are developing. So without any further delay, I put this in the hands of Dr. Masud. He's the head of the Center for Critical Care at Methodist, professor of anesthesia at Weill Cornell, and a fabulous guy who's done an amazing job, and I am totally indebted to you. Thank you so much for doing this.
Thank you, Dr. Q. So Dr. Quiñones, we affectionately call Dr. Q because he's been so well respected, and he's really a leader of cardiology and echocardiography. You know, if you want to know about echo all over the world, they know Dr. Q. So thank you, Dr. Q. So this edition of Cardiac Critical Care is a second edition. We did the first one almost about 4 or 5 years ago. 4 years ago. And we felt that this is really time to come back. And I'm so fortunate to have surrounded by fantastically very smart, very thought-provoking colleagues who wrote these articles, and the reviews were done. And you know, today is the day to kind of have to understand with them some questions from them and kind of insight what are their input in that. So we're going to start, with some questions. We're going to start first of all with Dr. Atiya Dalla. Dr. Dalla is the Associate Professor of Clinical Surgery, Department of Surgery for the Center for Critical Care. So welcome, Atiya. Thank you for joining us.
Thank you.
And let me tell you before...
Thank you, Dr. Masud.
Yes, so before we go a question, I want to share with the audience that Dr. Dalla is so gracious enough that she was visiting family in India, and it's 3 in the morning. So thank you, Dr. Dalla, so signing up to be awake, and you can see her commitment and passion at 3 in the morning. She's up fresh. She looks much more fresher than me. So,
absolutely.
Okay. All right, so the topic Dr. Dalla and the team wrote was integrating a virtual ICU with cardiac and cardiovascular ICU, managing the needs of a complex and high acuity special ICU cohort. Very unique, very thought-provoking, very leading medicine. So Atiya, so the question is, why is the virtual ICU so important to our patients and our future?
Yeah, thanks, Dr. Masud, and nice to see you, Dr. Quiñones. I call this the Houston Methodist Chennai campus. I'm speaking from 3 a.m. So I think that, the virtual ICU has become an integral part of the Center for Critical Care. It is an important part of what we are today in the moment. So why did we start this virtual ICU? The main driver or the strategic rationale for the virtual ICU was staffing shortage. And I think we have overcome that issue. And the night intensivists, their shifts are cut down by 50%. What enabled us to have this virtual ICU was the technology. And then the amplifier was COVID. And once COVID hit, it amplified the need for the virtual ICU and also its delivery. So the other thing about the virtual ICU in the present moment is its scalability. So we can turn on beds in a moment. So during the surges, we were having pop-up units, units that were turned on. So beds can be turned on. Right now, we cover all 15 ICUs in Houston Methodist system. And that's 351 beds. And we can turn on more beds as needed. So I think that's the present. The other thing that happens that's great and unique is the mentorship opportunities for the bedside newer nurses by the very talented and experienced virtual RNs. So I think that's a great thing. Multidisciplinary things have been set up in the virtual ICU. That's another thing in the present moment. The future for virtual ICU thing is going to be extremely promising because if you look at a brick and mortar, ICU, you only look at patient-specific data in the moment, taking care of that patient. But all of this big data, the machine learning, the predictive analytics, is dependent on all this data and the predictive analytics are in the near horizon. We are going to be able to predict cardiac arrest, for example. We are going to have, decompensate, decomp prediction. So we will know a patient's going to decompensate before it happens. So all of this is very, very promising. I can talk more about it, but I guess the time, and I'm sure everybody read this article, and there's a lot more in the article that we've spoken about.
Thank you, Athiya. I know that's a small glimpse of what you and your team wrote about, and I agree with you. There's a lot more solutions in the article. Quick follow-up question, you went through it, you're the whole team with it, along with Dr. Tuazan, Dr. Dean, and all the stuff. If you had to do this again, what would you do differently? So,
there's always things you can do differently, right, Dr. Masud? And for this one, I felt we could have done it slower, more methodical. There's always things you can do in the area of change management because you're introducing a new technology. And then, you're introducing new MDs on the virtual MD side. So I think early cross-pollination. So if we had bedside intensivists that also worked in the virtual ICU, I think that would have, bred more familiarity with the bedside staff. I think that's one thing that comes right out of the mind to do, earlier on in the process. And I think, workflows, all those things, I think we tweaked and we did the right things, but we couldn't do it slowly and more methodical because it was COVID. And the launch of our virtual ICU coincided with COVID, and we really had to scale up, and we had to scale up really fast. And people were saying, turn it on. We need the virtual ICU. So we couldn't do it in a slower, more methodical way. But I guess for people setting it up, I think cross-pollination earlier on, slow, methodical, especially when you're bringing such a big change to the
If I can
hospital.
ask a question, you literally dived into it because of COVID. And my question is, having to do it so quickly and efficiently, what was the acceptance level that you saw by everybody, by the anesthesiologists that had to sit there and do it, by the physicians whose patients you were caring for, and even the patients? I mean, how well was this accepted through? Did it take a little bit of time to get it accepted, or was there a quick acceptance just simply because of the crisis of COVID?
Yes, during COVID, Dr. Quiñones, it was, I remember that, because it was, what virtual ICU helped is that we didn't have to don and doff. Every time we would enter the room, we would have to don. And then every time we came out, we had to doff. That was so much time. Here, if there was a nurse that was in trouble in the room, she would just hit the button and then the virtual MD would appear, and we were able to, help out a lot. So it was very much accepted during COVID. And in fact, people were like, Athiya, we need to turn this on now and fast. We also had set up, laptops, Dr. Quiñones, outside the ICU, so we could actually monitor our patients without having to enter every time. And we could look at their vitals and, and do it. So I think during COVID, I would say the acceptance was a lot faster and better.
So I think, COVID helped you kind of expand, but probably you might have resisted a lot more resistance, but every crisis is an opportunity.
An opportunity, absolutely.
All right, thank you, Dr. Dalla.
It was our silver lining for sure.
I know,
yes.
Thank you, Dr. Dalla. So it is my pleasure to talk to our next speaker and writer, a very well-known internationally name for critical care, Dr. Ashish Khanna. Dr. Ashish Khanna is a Vice Chair of Research, Department of Anesthesiology and Critical Care at Wake Forest, and is a Director of Peri-Operative Outcomes and Informatic Collaborative. As you can see that he wears many hats. So thank you, Dr. Khanna, for your article on blood pressure goals in the critically ill patient. I think you've been talking about blood pressure for a long time, and so my first question really is, you have been talking about blood pressure for a long time, and you're trying to make people see the light. Why is this message not resonating and not so widely accepted so far? So tell me, you're right, I think you're right, but what's going on?
Thank you, Dr. Masud, and thank you for having me and the opportunity to write for the Methodist DeBakey Journal. So your question is really important, but I'd like to sort of look at it from 2 or 3 different perspectives. Number one, if you look at the evidence, and we've written about this in the blood pressure goals and in the critically ill article that you're referring to, an overwhelming amount of evidence is retrospective data sets that have looked at associations of different blood pressure thresholds with organ system injury, mortality, and so on. Now, we have seen that higher than conventional thresholds, so conventional threshold being a MAP of 65, higher than conventional thresholds may also have a risk associated with organ system injury, meaning thereby that a MAP of 65 may not be the one size fits all for everyone. Now, while this has been seen in retrospective data sets, association doesn't necessarily mean causation. And there has been very few and far between interventional blood pressure targeted randomized trials, especially in the ICU. In fact, there's actually just one large randomized trial of blood pressure targets in septic shock resuscitation in the ICU, which is the very famous trial that was published in the New England Journal almost 10 years ago by Pierre Aspar and colleagues that showed no difference of a higher versus a lower mapped target. Now, keeping that in perspective, it's been difficult to convince colleagues and collaborators and peers that different blood pressure targets are necessary. On the other hand, I'd also like to state in the same breath that's very difficult to perform interventional randomized trial of blood pressure targets in the ICU. Now, even if you look at Pierre Asfar's work, they were about 5 millimeters mercury more than their initial planned blood pressure targets in both of their interventional arms. And that is the whole problem with setting blood pressure targets in the ICU. We always tend to overshoot on our targets. Number two, no IRB or ethical committee will allow you to randomize a patient to true hypotension in the ICU. So I haven't read an interventional trial where people were randomized to a BAP of 50 or 55, right? And because, you know, common sense tells us that hypotension is bad. But on the other hand, people want to see that level of evidence before they say, oh, you know, let's make a change and set ourselves different thresholds. The other issue, really quickly, and I talk about this a little bit in the write-up as well, is that in the end, what blood pressure is a sweet spot for you, Dr. Masud or Dr. Q or other members on the panel, is not the same sweet spot for me. And the problem is that we've tried to like put people in these buckets of blood pressure, MAP of 65, 75, 85. That's not the case. All of us are living at a specific sweet spot that our organ systems have gotten used to over the years. And again, I give that example all the time, saying, you know, folks who've had long-standing chronic hypertension, for example, you cannot, you know, give them a MAP of 65 and say that it's fine when they've lived at a MAP of 90 for 10, 15, 20 years, right? So I think that is one other problem. We have moved away from personalized medicine, and we've tried to do these randomized trials of putting people in large buckets, right, and of MAP thresholds. And that, you know, we're never going to be able to see an outcomes difference. And I think that has been more or less the challenge. However, I will say that all is not lost. I'm very, very hopeful, and especially people read and educate themselves and reorient themselves and have time to spend time with the patient, and they want to do things slightly differently, that they should be able to, within reason, do things differently in the ICU.
Well, that's very fantastic. You know, you laid out the case for how difficult it is to do any kind of meaningful trials in the ICU. You know, and do no harm comes into place. So I know you wear a lot of hats, and you've done a fantastic job in informatics, artificial intelligence, machine learning. Do you feel that some of those tools can be a resource in place or supporting some of the trial limitations you have expressed?
Yeah, Dr. Masud, I think, let me just start by talking about the electronic medical record, for example. I think the EMR can help us. I think data management systems in hospital systems can help us. And I guess data unification across countries, across continents, and across the world is going to help us. We've just started thinking about all of that. We have a long ways to go. But just as an example, you know, if you look at your EMR, or if you look at commonly used EMRs, EMRs will capture not every blood pressure reading from a bedside ICU monitor, right? They'll capture something that's probably once in 15 minutes, once in 30 minutes. We're losing large amounts of time of blood pressure changes or pattern changes that should be captured, but are not being captured because currently most EMRs are unable to handle that large volume of data, right? Again, there is now the availability of middleware that can interface itself between the EMR and the patient's bedside monitor and capture every single vital sign. That's probably the way to go, you know, if we really have to develop those machine learning models. The other aspect of machine learning is that machine learning doesn't all the time rely only on numerical values. So while the numerical values are great, what machine learning really relies on is pattern detection that's going to be based off of physiological waveform data. So waveform data being as simple as, you know, pleth trace from a pulse oximeter or an arterial line trace, right? right now, very few institutions, very few data handling systems actually capture waveform data that all of our ICU patients are generating every single minute, all over the country, right? And we have to make an investment into all of that if we have to develop better prediction models. And then finally, when people talk about precision medicine and sort of, what is that sweet spot? I always tell them, we wear our Apple watches and other wearables. Unfortunately, the wearables, these Apple watches, these other watches, these digital Fitbits are capturing a lot of our physiological information, but we're not transferring that information to our treating critical care physician or to the researcher who wants to do research on my cardiovascular target. We unfortunately, are forced to take off if I were to get admitted to the ICU, the bedside nurse will tell me, okay, you can leave your watch here in a bag and I'll take it away and give it to you when you recover, right? So we're not really using all of the wearable technology we can at home and not allowing that data to get transferred into EMRs and electronic health records. So I think we need to join all of those dots, that we need to create better prediction models in the future with all of this.
That's a fascinating take on it. I'm so, I'm so intrigued, and I think with you engaging people at different continents is going to be meaningful. And for those who are also listening in, again, kudos to Dr. Khanna. He is also traveling, and he is so gracious enough to log in to communicate with us. We're really appreciative of your effort and all the work that you're doing in so many fields. So thank you, Ashish. It's always a pleasure talking to you.
Thank you, Dr. Masud and the editorial board team. And I'll say, after I heard of Dr. Dalla being in India, I'm in Nashville right now, which is nothing compared to what she's doing. So please, all the credit goes to her.
Okay.
So, I'm down. There's no need to thank me at all. Thank you so much.
Thank you, Ashish. Okay, now we go a little bit more in person. I have the pleasure of sitting next to me, Dr. Iqbal Ratnani. Dr. Ratnani is the Associate Professor of Clinical Anesthesiology and Critical Care and at Weill Cornell and Department of Anesthesia and Center for Critical Care at Houston Methodist. Welcome, Dr. Ratnani.
Thank you.
So Dr. Ratnani wrote a topic in vasoplegia. And the fascinating part of the vasoplegia is that it is so common but not very well understood, and not many therapies very well defined. And if you go to his article, which I really thoroughly enjoyed, he lines up all the treatment methodologies and everything. So I'm going to let you all go in deep dive. I'm going to pick up the controversial part of that. So the controversial part is, tell me, how do you compare methylene blue and cyanocobalamin in treating vasoplegia? We see that being used in many places. So let's pick up the controversial part of it. So Dr. Ratnani?
You know what, Faisal, when we were writing this article, we went back and did the literature review again to see that if there is anything in literature, and I always tell my students and audience that always not read the article, also read the references. So if you look at our article reference number 10, we reviewed up to 2022, and we did not find up to this point, despite vasoplegia is the most dreaded situation when people come out of the OR, there is no evidence-based guidelines. So what I will be talking here, the only thing we have, which we have put in reference 7, is the sensitive predictive model. That's the only thing we available. So I'll be talking a lot more from the anecdotal and the clinical experience. And our anecdotal experience matters because we are large volume center. We are doing this for a while, since the time of Dr. DeBakey. And lately we have found in last couple of years that cyanocobalamin, vitamin B12, bolus 5000, is working better than methylene blue. That's the anecdotal, what I have heard from anesthesia when they are doing perioperatively, we are doing on the bedside. And there is another reason that why we are slowly walking away from methylene blue is that because we are doing a lot of devices now. We are doing a lot of LVAD, and many of these patients are coming on nitric oxide, RV failure. And when you use methylene blue, it gets very difficult to use nitric oxide. So that's one of the reasons that we are going towards cyanocobalamin. The second reason is that at least in one instance, or at least two actually, I know that patients went into, as soon as they get methylene blue, they start having tachycardia, fever and all those things, and went into serotonin syndrome. And now all this medication, SSRIs, are so commonly used as an outpatient, sometimes they get missed. And methylene blue is given, and the drug interaction with SSRIs of methylene blue can actually cause a lot of problem. So these are the clinical reason and our anecdotal experience. Again, I will emphasize that we don't have any real evidence-based guidelines, but from our experience, we found that cyanocobalamin. So if you are asking me to take a side in this controversy, my side would be cyanocobalamin.
Okay.
So
Well, very, very good take on it. I have to rethink now. So, especially for device patient, we do. We talk about, in therapy and science, about multimodal approach. We talk about pain management as multimodal. We talk about a combination of things to minimize side effects. So, Dr. Ratnani, what is your take on the multimodal or multi-receptor targeted approach for vasoplegia?
You know what, Faisal, vasoplegia is like raising your children. You deal with them every day, but you don't know what you are doing. I have written on vasoplegia, I have done grand rounds on vasoplegia, and I'm here again writing review articles. But if you ask me a question, I will be on the shaky ground to say what to do. So that's how it is. But to answer your question is that I will go back to Dr. Khanna. And Dr. Khanna said a very beautiful thing, that in this era of evidence-based medicine, and now we are moving towards the precision medicine, during the evidence-based medicine, we got so obsessed with the processes that we actually forget about the outcomes. So, and that's what Dr. Ree was talking when you did the sepsis symposium on last week. That was a very great symposium. So that's one of the things, is that when people are coming with vasoplegia to our ICU, we are using volume, pressors, cyanocobalamin, methylene blue. People have tried midodrine, doxidopa, even vitamin C, head trial. But I believe that as I said before, we don't know exactly what is really working, and every human is different. As Ashish was saying, Dr. Khanna was saying, that the precision that every person has a different blood pressure target. Similarly, every person react or respond to. We have seen patients who don't respond at all to cyanocobalamin, but we have seen patients who just respond simple to midodrine. But if you ask me my experience, what actually works, giving time to the patient, and if one modality, starting with the lowest, least lethal, going upward, and give some time.
So I'll have a follow-up question that, we look at the receptor, whether it's alpha receptor, a vasopressin receptor, an angiotensin receptor. Do you think there is a role of a combination of, norepinephrine, epinephrine, vasopressin, angiotensin 2, because these are the at least commercially available and easily available quite a bit and most of the places. So is there a role of these three agents and combining the three receptors to have a little bit of all three agents or one agent? What do you think about that?
You know what, I usually start with volume, and in vitro, the experiments have shown in animal models that actually the combination of norepi and vasopressin works better. So I usually start with volume and then go to norepi, and if norepi is not giving me good result by 4 or 5 mics, I usually jump to vasopressin combination, norepi vasopressin combination early in the course. Angiotensin 2, we don't have much data on it. We are using it, and we have used it with success in many patients, but that's what I keep as my last weapon.
Okay, so you're thinking, the way I see it is that you're using volume, you're using norepinephrine, vasopressin, on and off angiotensin, and then you choose to use cyanocobalamin if needed versus methylene blue.
Right.
So we got your recipe, Dr. Ratnani.
Thank you.
If I can ask a question.
Please.
So vasoplegia basically is a patient that has profound vasodilation,
Yes.
low blood pressure, but a high output.
Yes.
Now, is the vasoplegia of a septic patient similar to the one coming out of the OR from a pathophysiologic mechanism? Do we know all these pathophysiologic mechanisms Or are they different animals? The one coming from the OR with this versus the septic guy who has, positive blood culture, sick like a dog, and has vasoplegia?
Yeah, the final pathway is the same.
This
But
final
the
pathway
final
is
pathway
the
is the
same.
same, but the
Okay.
initial pathway is different. And the initial pathway in vasoplegia is most driven by the INO, nitric, in the endothelium. That's why we try to target those first.
So is there any difference in how you manage the septic patient versus the guy who's coming from the OR?
Yeah, in septic patient, usually we have a lot of, because we know that there is a source sitting somewhere. So attacking with antibiotics,
Right,
and that's the biggest thing on the sepsis. But the volume is the same, and in vasoplegia we go towards pressure little early than in sepsis. So there are different guidelines and all those things, but volume stays still for the
Still the
sepsis,
same.
but here we go for the pressures little early than the septic.
So I know it's a big topic because that's a very common thing from the OR. In septic shock patient, the recommendation from the guidelines is to use norepinephrine as a first agent. Is that the same approach that you have if the patient coming from a post-VAD or a post-long pump from vasoplegic? Would you use vasopressin as the first line or norepinephrine front line, because, in septic shock, there's a recommendation for norepinephrine. What is your approach?
There is no guideline, so we go with our experience, and our experience is very good in it that we start with norepi, but we are very quick to add vasopressin.
Okay. So, okay. Well, thank you. This is a very engaging discussion, because that's a problem we deal on a daily basis. All right, so we're going to take a slight, deviation on a problem which is not necessarily commonly managed by cardiac surgeons or cardiologists or heart failure or, vascular surgeon. However, this is a problem which is faced quite a bit in the ICUs, and then, we really want to have a dialogue on this, and this topic is acute respiratory distress syndrome in patient with a cardiovascular disease, and I have my pleasure to have Dr. Asma Zainab. She's an assistant professor of clinical anesthesiology in the Department of Anesthesia and Critical Care at Center for Critical Care in Houston Methodist. She's very, very passionate, engaged, has done a lot of work on ARDS and lung injury. So I could not think of any better person. Thank you, Dr. Zainab. So let me bring the first question because we have a very diverse audience. How do you bridge the, both inpatient and out of hospital cardiac arrest? There is a very high incidence of ARDS with worse outcomes. Tell us more about the incidence and factor causing ARDS during cardiac arrest, because the cardiologists and the cardiologists see this more firsthand. So can you shed some light on it?
Yeah, sure. Before I start, I wanted to say when Dr. Masud gave me this topic to write on ARDS and on cardiovascular patients, and I was like, ARDS is ARDS. How is it going to be different with the cardiovascular patients? But once I started digging into, I realized it's a huge topic. And we may not find like a specific review article just putting it together. And then once we started putting it together, then it was like putting like a huge amount of knowledge into a small article. So one of the important things that we learned while we were collecting all this information regarding ARDS in cardiovascular patient is the incidence of ARDS in cardiac arrest patients. I did not realize like more than 50% of the patients with in-hospital cardiac arrest within 48 hours have a high risk for ARDS development. And in one of the study for out of the hospital cardiac arrest, the risk goes up to 50 to 70%, which is a very high incidence. The problem is like the time range for this ARDS development is for 48 hours to 3 days or 72 hours. And the risk factors basically, of course, aspiration is one of the biggest factor. And then CPR by itself, the chest wall injury and lung parenchymal injury secondary to the CPR can lead to contusions and ARDS. And the third one, which is also very important, is the ischemia and reperfusion injury after the cardiac arrest. The biggest problem with the ARDS in these patients is that you have to be very vigilant with these patients who survive 48 hours or 72 hours, because if you think about starting a lung protective, a low tidal volume strategy in patients to begin with, then you're talking about starting increased sedation, which will affect your neurological assessment and all that. And hypercarbia by itself, because of the low tidal volume strategy, is also not a good idea for the ARDS. So over here for us, the most important thing will be being very vigilant on these patients, to monitor closely to see if these patients develop ARDS.
Very interesting. Dr. Q, what do you think? How many cardiologists thought that after a cardiac arrest or cardiac events, patient will be developing ARDS?
Absolutely. This is truly educational, because as a cardiologist, you think of the brain. The heart is back in sinus, good. So you resuscitated the patient. The next thing is the patient going to wake up? And all that efforts are put in, including hypothermia and everything, and nobody really thinks about the lungs. And what you just mentioned statistically is pretty impressive.
Yeah.
50-70% of patients may go into ARDS.
And then another problem with these patients is, like, the patients who do develop ARDS, the prognosis actually is poor. So I guess for the ARDS in these patients, the most important is knowing that recognizing the ARDS, and then proper ventilator management.
So how do you protect them from ARDS?
So
what's the magic tools to keep them from having ARDS?
Not much out there, but again, the main thing goes with the lung protective strategy, keeping in mind the heart. We used to do low tidal volume strategies and all that, and in these patients now the focus is more on having a plateau pressure less than 27, a driving pressure, so that your mechanical force on the lungs is not too high. And at the same time, we also know, like, okay, while you are trying to save the brain and the heart, the ARDS by itself will creates pulmonary vascular disease leading to the RV dysfunction and failure. So it's like once you are in that cycle, then it becomes like very difficult to stop at some point.
Very interesting. The question is, once you develop ARDS and you've recovered from your acute cardiac injury, what is the prognosis of such patients? You mean, do they ever get off the ventilator or not, or are they higher risk than compared to somebody who developed an ARDS because of pneumonia?
So are we talking about the CV patients in general?
Cardiac patients with cardiac events.
So what is very interesting in these patients is, like, we do know, like, both heart and lungs are sitting in a cavity, and they share the same space, and they are both organs which expand and contract, and both have pressure and volume curves that we talk about. And equally important is, like, one can affect the other. So, but more interesting on that is, like, cardiologists and pulmonologists each think differently. Like, when if it's a heart is important. When it comes to the lungs, lung is important. While I think they both cannot do without each other. And more recently now, we are even talking about the cardiac phenotypes in ARDS, which actually affects the prognosis of the outcomes. Like, especially if the patients there are 4 different phenotypes which have been identified with the normal LV, the RV, which is dilated but function is normal, the patients who have RV failure, and the 4th one is a high output patients with a very hyperdynamic LV. So you would normally think that the patients with hyperdynamic LV should be okay, or RV dilation and RV failure is the patients which have a poor prognosis. But not only RV failure has a poor prognosis, but those patients who have a hyperdynamic LV also affect the prognosis equally bad. The third thing which is also important equally is, like, the ventilator by itself, because prognosis also depends on how long you are staying on the ventilator. And of course, like, we do recommend a lot of these patients who meet the criteria for ECMO is to go on ECMO and come off of the ventilator earlier, because just to prevent the ventilator-induced lung injury, which is equally bad in these patients. And prognosis all depends on the length of the ventilator. All of these patients on top of that have a cognitive impairment. Even by the 5th year after they have recovered from the ARDS, a lot of these patients will still have cognitive impairment. So all of this, I think, comes in together. It's like not just one thing for the prognosis.
So, Dr. Q, I think you all have to think not only the heart, brain, but the lung also.
Absolutely.
Yeah.
Yes.
We'll have to teach you about driving pressure, give you
Yes,
cheat
right.
sheet on driving pressures and things like so. No, this is fascinating. I think thank you, Dr. Zainab, for sharing, because this is something not very common knowledge, and I think what also it emphasizes the point that when you have such a sick patient, the communication and the dialogue between the cardiologist, the cardiac surgeon, the intensivist, the pulmonologist is so crucial, because we all are trying to aim the same goal. We cannot have competing goals, whether it is drips, fluids, and everything.
We should repeat that several times.
Several
No,
times.
absolutely.
I agree.
That is crucial. Yes.
Okay, well, thank you, Dr. Zainab. That was a very, I didn't think that topic was so much layers of complexity, but thank you for, and again, if you read the article, you'll find a lot of solutions, a lot of things to review and analyze, and I think Dr. Zainab and her team have done a very in-depth detail, and there are a lot of takeaway points from that. So thank you. We're going to go to, yet again, we're going to go to a topic which is really kind of to some degree, when lungs get into trouble, when the devices can't do anything, then what do? Then you call the ECMO team. And, ECMO in the last, I would say 15 years since the SARS and since the COVID is really taken a forefront, especially in cardiac patients. The fear of ECMO is a lot dissipated. With that in mind, we had a fantastic author, Dr. Faisal Akbek. He is in the Department of Anesthesia and Critical Care at the DeBakey Heart and Vascular, critical care, excellent physicians, leader, who really, and his team wrote an article about extracorporeal membrane oxygenation in post-cardiotomy shock patient. Again, patients who are in not only from a cardiac standpoint in trouble, but overall organ trouble-wise. So thank you, Dr. Akbek, for writing about it. Let me start with this thing. And again, we're going to start with some controversial topic, because I want the audience to read the article or the easy stuff. We're going to bring the controversial stuff. So how does one make a decision between an Impella and ECMO? The heart is not doing well, you're on a ventilator. So how does the cardiologist, the cardiac surgeon, the intensivist make that decision?
Yeah, thank you so much, Dr. Masud, and thank you for having me. The decision to choose between VA ECMO and the Impella depends on the patient presentation. We know the Impella provides support to the left side of the heart, but if the patient has biventricular failure, then this is when VA ECMO probably will provide better support to the patient. The other indication to choose VA ECMO over the Impella is like what the subgroup of cardiogenic shock that we talked about, the post-cardiotomy shock patients. These are patients who cannot separate from the pump. They are on high-dose vasopressors and they are not responding, with some evidence for end organ failure. So this is when the surgeon chooses to implement the VA ECMO to support the patient. And a lot of times, if it's a valve patient, he has a mechanical valve, he might not be able to cross the valve to put the Impella in, or there might be some anatomical problem because of the surgery or because of the patient comorbidities that prevent the Impella from being placed. Let's not forget that when the ECMO is being implemented in these patients, it's something emergent that you need to do. So in some situations, the VA ECMO will be placed while the patient is being coded in the ICU, while the team is doing CPR. So in this population in particular, probably VA ECMO, it will be easier or faster to implement. It will provide a faster support and a bridge to more advanced therapy. The surgeon or the heart failure team that is being involved in the case might place the patient on a VA ECMO, and then when they have more information about what's going on in the patient, when the dust settle down and the clinical picture is more clear, they might bridge to an Impella and withdraw the VA ECMO, or put the Impella in and we create what we call eCPella, where the patient is being supported with VA ECMO, and at the same time you have an Impella in place to vent the left ventricle.
So again, so there will be no fighting between the cardiologist, cardiac surgeon, and anything. So they will mutually agree what the strategy. That's very good. I know your article talks in a lot more detail in terms of managing these patients and how to look for and everything. It does bring up a fundamental issue is about, ECMO is a very resource intense device. from cost, from people, from everything. What is the downside of implementing so many ECMOs if we start putting a lot more of these ECMOs, especially the VA ECMOs?
Yeah, that's a very important question, Dr. Masud. Yes, I mean, ECMO is very intensive therapy, and as any therapy in medicine, it comes with side effects. And we all work on the ICU. We know how much work and how much manpower it takes in order to take care of an ECMO patient. I mean, you're gonna need an experienced team. You're going to need a physical therapist, a nutritionist, a physician, and then we keep looking for the complications, including bleeding and other complications also too. So, like everything else in medicine, I mean, you want to use this support, this therapy in the right patient in order to get the right outcome. So, the choosing criteria, knowing which patient would benefit from the therapy, it's very important, and that's why we mentioned in our article that if you have a patient who have risk factors to develop post-cardiotomy cardiogenic shock, then the planning should start actually before the surgery. The multidisciplinary team discussion should happen, optimization of the patient in the ICU should happen also too, and then a discussion between the team members about if the patient, doesn't do well after surgery or he developed a refractory shock, are we going to offer ECMO in this patient? Is this patient gonna benefit from ECMO? So that's the planning part that should happen before surgery in order to utilize this resource in the best way.
Well, you brought up a very important point. Okay, go ahead.
So as a clinician, I see this as a real problem. And even though you look young, I'm sure you've been doing this for a while, and I have taken care of a lot of ECMO patients. And of course, probably a lot of them that have not done well. So can you tell us, like, in your mind, who is the ideal ECMO patient? And on the other side, who is the kind of patient that you really would say to the physician that's asking you or the family, this is not the right tool? Give us the two extremes. The ideal patient for ECMO and the one that you really would say, we should not go. We should not do it.
Yeah, very, very important question, Dr. Quiñones. So I would say the patient who would benefit from it, it's hard to tell, to predict which patient is going to do well or not. We know the older the patient is, probably he's not going to do as well. The more comorbidities the patient have, also that can affect the outcome. What we know from the data is implementing this therapy, the earlier is the better. So if you have someone post-surgery that you see that the lactate is rising and you're escalating on the vasopressors and the inotropes and you're not seeing any improvement, if you see signs for organ failure, the liver enzymes are going up, the creatinine is going up, despite all the support you're providing, the SvO2 is dropping, probably this is the time to implement this therapy in order to improve the outcome. If you wait too long until the lactate, in the literature, they mentioned that if the lactate crosses the level of 10, then implementing the ECMO after that, you're going to have a bad outcome. So the earlier you think about it, and the earlier you implement it, the better outcome that you're going to have. And also the other thing is, after implementation of ECMO, the care that is being provided in the ICU is very important. Getting this patient off mechanical ventilation if you can. If not, if you have someone with an open chest, then thinking about a strategy to closing the chest quickly and moving to a different cannulation strategies in order to wake up the patient, getting the patient out of the bed, start physical therapy is also very important. The longer you keep this patient also in a central cannulation or an open chest, then the more infection rate you're going to have, the more bleeding, and then the outcome is not going to be good. So to say which patient probably is the best to place, and I would say, again, planning ahead, knowing which patient, if he has one single organ dysfunction, patient probably would be more on the younger side, I would say, below the age of 60. Patient who doesn't have any other organ failure, patients who doesn't have any neurologic deficit or don't have renal failure, probably these are the patients who would do better. Which patient we should not offer this therapy to? Again, it's not, as in our institution, Dr. Zainab and Dr. Ratnani, it's always a tough decision, and it always requires a discussion between the surgeons and also between the ICU people. looking at reviewing the patient case and then decide, is this patient going to do well or not? So it's a group decision probably. And that's why every center is implementing like a committee to decide which patient should go on ECMO and which patient should not.
Is it fair to say that the patient with ECMO that has the best outcome is the one that is mostly respiratory failure, but with a fairly good heart? Like young people that have, for example, severe influenza, and for a while their lungs are not working, you put them on ECMO and eventually they recover. Is that kind of the best scenario for ECMO?
I mean, if you have only the lung involvement and
Yeah.
the heart is doing okay, probably if you have someone who is also a transplant candidate, is probably relatively young, I think he will do well. If you have someone who has heart failure to start with, borderline kidney function, and then he goes on ECMO, now he's on dialysis, the heart is not doing okay, there is nothing much you can provide for him, there is no what we call exit plan, he's not a transplant candidate, this is probably a patient who's not going to do well.
Right. And the best scenario for a cardiac patient that is in shock and goes into ECMO, what statistics do you normally give the family? I mean, we're going to try to do everything we can, we're doing this and that and that. We're expecting, the chances are what? 40%, 30%, 50%? What do you normally quote to the family?
Yeah, so that's also an important question. So every center experience is different, but we have the results from the ELSO registry about the post-cardiotomy patients. The outcomes, actually, the mortality is around 50%. So despite that we have been doing this for a long time, the mortality is still quite high. Probably around 40 to 45% also make it to discharge out of the hospital. That's why it's very important to choose the right patient to provide this therapy.
Right.
Excellent.
Thank you. Very, very good discussion on that. I'm going to go back to our first speaker, Dr. Atiyadala. As you have employed the virtual ICU in your team, you work with ThingWise, and more data is becoming available. What are kind of quality metrics and outcome metrics that you think you look forward to studying in the future? Because this technology will be incorporated more and more in cardiac ICU. So what metrics or data that you think would be meaningful and you would like to look and study?
Yeah, it's a great question, Dr. Masud, and I think we can group them into different buckets. So one will be what would be the clinical outcome metrics, and those are ICU length of stay, mortality, number of code blue events, and in our paper we have outlined that we had a decrease in code blues in our ICUs. So those are the clinical outcomes. And then with the Apache 4 data, we're able to predict ICU length of stay, ICU mortality. So all that is available right now. Then looking at the VICU process itself, what is the responsiveness of the VMD? How quick is the response? How is the audiovisual response? The notes, the activity by the virtual MD. Then the utilization metrics. How often is the virtual ICU being actually utilized? And is that making a change in the outcomes? Then there's the technology metrics. How quick does the camera turn on? All the audiovisual connections. And then the econometrics, economy. Is this causing a return on investment? Are we decreasing length of stay because we're catching things earlier? So all of those things will be available. And then also, I think for the technology metrics is the virtual ICU now able to predict, cardiac arrest earlier. Are we able to have, realize the patient is decompensating earlier? And I think one of the biggest thing that I'm most excited about is even before the patient comes into the ICU, in the acute care units, let's say, there is availability of these virtual platforms and data that are being monitored in our virtual ICU by telenursing, where we can actually pick up a patient decompensating in an acute care unit and bring them into the ICU earlier. to improve their outcomes. So I think there's a lot out there, and obviously, there's so much layering of data that flows into the virtual ICU. You have the bedside data, you have the data from the electronic medical record, the lab data, the ventilator data, so the waveforms. And then we have, I think eventually radiology will also come into there, and then there will be the personalized, individualized treatment for a patient, which I think would be the ultimate use of a virtual ICU, and that's what we call a smart ICU.
That's a very fascinating. This is the look in the future about Dr. Q,
the future, right?
How we see that. Let's go back to Dr. Ratnani. Dr. Ratnani, we talked about vasoplegia, we talked about therapies. What will be, you think, will be required to at least diagnose vasoplegia? Because, I hear from different people, and I see that also, that there is a lot, some of the cardiologists, cardiac surgeons, vascular surgeons feel that there is an overutilization of vasopressors by critical care specialists. Is it a fair or unfair? I don't know, but they do make that, this very focus to fix a number. So what do you take on this? How do you say it's really vasoplegia or we are overcorrecting? Any thoughts?
Yeah, I think, in one way, the vasoplegia is a diagnosis of exclusion if you don't have any extra bleeding, if you're not hypovolemic, if you have fixed, means if your patient is, so first you have to rule out that your patient is not dry. So you fill up the pumps and you fill up the vessels and everything, and then you are not bleeding. So if these two things have been ruled out and still you are seeing that low blood pressure, and if you have a SWAN, you are lucky to have SWAN and your SVR is still low, cardiac output is high, and all the numbers fit into it. But first of all, you have to rule out that you are not missing anything. That's why I tell everyone, that all my residents, fellows, that first look at the chest x-ray numbers, and if patient is not bleeding and not dry and still very hypotensive, then you are going towards vasoplegia.
Will there be any use for the handheld ultrasound? Taking a quick look and seeing that the heart is working with a great EF, and that most likely cardiac output is preserved or high.
Yeah.
Is that something that potentially
Absolutely.
could benefit?
I don't know how I missed when you were sitting here. I should have talked about that earlier. Absolutely. If you have an ultrasound, you put on the IVC, you look into that. Exactly. And many times when we have low blood pressure, now this is a normal trained in ICU to just get the ultrasound machine and put on the chest that it is ventricle is empty, if there is a pericardial tamponade or not. So that's how you rule out that putting your ultrasound probe very quickly into your IVC and into your heart. Absolutely, it's a basic thing.
Certainly, the stethoscope is in the closet.
Yeah.
We have so many other better tools.
Yes. All right, so I'm going to give you, Dr. Q, the last question to Dr. Zainab, because I think the cardiologists and the lung specialists, before I talk about wrapping up other articles.
Well, a common dilemma that we have with the pulmonary specialist is that the patient is sick, and the cardiologist keeps saying it's the lungs, and the pulmonologist keeps saying it's the heart. And that's, we joke about it, but it does happen more often than we would like. Why do you think that happens? I mean, so the cardiologist is seeing what he or she thinks is a heart that is doing okay, so he blames the lungs, but the pulmonologist is seeing something else and blames the heart. What do you think is the most frequent reason for that controversy?
I think if I specifically talk about the ARDS, then part of the reason is because, let's go back to the definition of the ARDS. We are talking about bilateral infiltrates. With a PA2-FiO2 ratio of less than 300, 200, depending on what is the degree of ARDS we are dealing with, what stage of ARDS we are dealing with. And we used to have we used to talk about the pulmonary capillary wedge pressure has to be less than 18 just to make sure that this is not pulmonary edema. We don't do that anymore. So by itself, it's a clinical diagnosis on ARDS, which can also look like a pulmonary edema as well, just based on the X-ray and the PA2-FiO2 ratio. So respiratory failure, either it's a heart and all that. But when we go into the specifics of like what caused this and whatever is going on, and like I just mentioned about the pulmonary vascular disease that we see in these patients with the ARDS, it's a new term that we have started using it because ARDS is a very heterogeneous disease. And what we see in these patients is like we have areas where we have over-distended alveoli, there are areas which are very atelectatic, and then there are areas which are where the blood vessels are vasoconstricted. The pulmonary vasculature is vasoconstricted because of the hypoxia. So all of that increases the pulmonary vascular resistance, and that in fact, if we start looking into that, will affect the right heart and then eventually the right ventricular dysfunction and all that. So I don't think that it's like one can be separated from the other. In mild ARDS, yes, we may not see all that because the chances of recovery are quick and all that. What we can say though, what is common between ARDS and between the pulmonologist and the cardiologist is we will both in this condition would like to have the lungs on the drier side.
Okay, so she found a resolution.
Yeah, and I think another thing is that a lot of cardiologists managing patients are thinking the left ventricle, and the RV gets ignored.
Yeah.
The RV is kind of like a little missing child because as clinicians we often ignore it, and then when we look at imaging, for example, with an echo, the RV sometimes is very hard to see. So I think the RV is sort of left out there, where you guys are thinking very clearly that the lungs are in trouble, it will affect the right ventricle. So I think part of the ways to come together is to bring the RV up and think more of it, because it does contribute a lot to either patient doing better or doing worse.
Exactly.
Yeah. Well, it's 6 o'clock in the afternoon, and we've had a lot of fun in an hour, and the time has gone real fast. And this has been an incredibly educational webcast. I hope that you all have been learning new things. I certainly have. And again, I encourage all of you to go to the issue and read the articles, because you will learn a lot more. I want to thank all of the speakers that have contributed, and especially Dr. Masud for an amazing job putting this issue together and bringing all of these wonderful people together. So thank you very much for being with us this afternoon, and have a good evening.
Thank you.
Thank you.
And that's a wrap.